Okay, I think we'll get started. So welcome to an evening with the Centre for Health, Exercise and Sports Medicine, often abbreviated to CHESM. I've browsed the list and I'm sure many of you know who I am. I'm Tim Sayer because I've been your lecturer for the Department of Physiotherapy, but I'm also associated with CHESM as a researcher. So this evening we'll begin with approximately the first hour, as you can see on the screen, dedicated to presentations from our three professors within CHESM. Following this, there'll be an opportunity to ask questions related to their presentations. So if you do have a question, I ask that you please put it in the chat box function, and I'll take down any questions that you do have and relay them to Rana, Kim and Adam after their presentations. Following this, we'll have about a 5-minute break, and then Tor will take over moderation for the second hour, where we'll hear from our postdoctoral research fellows and DPT students. So without further ado, it's my pleasure to introduce our first speaker, Professor Kim Bennell. Kim is a PhD qualified research physiotherapist and is the inaugural director since 2000 of the Centre for Health, Exercise and Sports Medicine. Kim is a Redmond Barry Distinguished Professor, which is one of the highest recognitions bestowed by the University of Melbourne. Kim has held several research fellowships throughout her career and currently holds a National Health and Medical Research Council Leadership Fellowship and is a Dame Kate Campbell Fellow. In 2018, Kim became a Fellow of the Australian Academy of Health and Medical Sciences, of which only 7 other physiotherapists were ever elected. Kim is a world expert in the field of osteoarthritis, and in addition to receiving numerous awards, is extensively sought after to speak, with more than 30 invited conference presentations over the past 5 years, ranging from the International Society of Biomechanics to the International Association of the Study of Pain. We are glad to have Kim tonight, so please take it away, Kim.
Okay, sorry, but I've been just choking for the last few minutes on it, so I apologise for that. Firstly, welcome. Thank you for giving up your time this evening to find out a little bit more about CHESM. And sorry about that. I'm just going to give a little bit of an overview about CHESM and some of the work that we've been doing, and you'll hear from the others. Sorry. Okay. So Michelle said she wanted me to start with a little bit about my personal story of how I sort of got to where I am. So I thought what I would do is start with the very bad perm in 1986, and I finished my physio degree and excuse me, went into working straight after for a couple of years at Box Hill Hospital, which I really enjoyed as a clinician there, rotating around. And all the drinks here, I think this is my going away party. I don't think that was just our daily lunch. But after spending a couple of years there, I did what many Australians did. I took a year off travelling around Europe in a combi van. And then when I came back, I started working at a sports medicine practice and also at La Trobe University as a lecturer there. So I decided to do a PhD at that stage. You know, it's really because I really found the research side of it really fascinating, probably more so than the clinical side of it. So I did a PhD with Olympic Park sports medicine people there, looking at stress fractures in athletes, and finished that in 1996. And then straight after that, I got a position as lecturer at the University of Melbourne, and obviously you can see I haven't even left. So for the last 25 years or so have been at the university. And in 2000, the Department of Physiotherapy established the Centre for Health, Exercise and Sports Medicine as a formal university centre, and our facilities that are there at the moment in 202 Berkeley Street were opened in 2004 by the then Governor General John Landy, sorry. So that's sort of a little bit of a history of me and why I really liked, I suppose, about my job. I liked finding out, doing research that could answer questions that were interesting and that were important and that could make a difference. And most of our research has now been around osteoarthritis. So I really enjoyed that aspect of it. What I also love about my job is that it's very flexible and lots of things happen. We get to travel to conferences all around the world with colleagues, and we always get to tack a bit of travel and seeing sites with, as I said, colleagues that you'll recognise there. We also get to collaborate with people from all around the world and take part in very interesting projects. We get to share the highs and also probably the lows as well, but the highs and the successes of one another together, which is, you know, it's a great team to be part of. And really importantly, you get to help mentor the early career researchers, so the researchers of the future. And that's a really exciting part of the job as well. So from my perspective, I think the research has position and being a researcher has really been, for me, it was a great choice back then. So a little bit about CHESM then. As I said, it is a formal university centre, which means that we have to have an advisory board and we have to have 5-year annual review, 5-year reviews by an independent body to look at our progress and to see whether we can continue. We're a multidisciplinary centre, so even though we have a home in the Department of Physiotherapy, we actually have a lot of different disciplines, people from physio, medicine, engineering, podiatry, exercise science, psychology, which makes for a lot of really good input and lots of different perspectives. And currently we have 23 staff and 9 PhD students, so a really good team. We have a human movement laboratory, which is in Berkeley Street, and that has a lot of equipment that enables us to look at 3D motion analysis. And I'm sure you'll hear from Adam about a lot of the work that they've been doing, particularly using this equipment. So it's a really world-class facility there, if you've ever wondered what's behind the curtains. And we've really been successful as a centre, which is because of all of the achievements and the work of all of the team members there. And this is just a summary over our last 5-year review. You know, we've had a lot of grant funding, a lot of research publications in very high impact journals such as JAMA and British Medical Journal. Excuse me, sorry. We've, you know, collaborated, as I said, with people from around the world, lots of different countries and organisations. We've had a lot of very good and ongoing partnerships over many years with Medibank and Arthritis Australia and ASICS, and to name a few. And we've had a lot of research high degree student completions as well. CHESM has 2 main research programs, the musculoskeletal program, which is co-led by myself and Rana Hinman, and we mostly do research into osteoarthritis. And then Professor Adam Bryant leads the sports medicine program, which has a focus on knee injury, but also looks at other injuries as well, such as ankle injuries, and you'll hear about those. So with regards to the musculoskeletal program, we mostly look at non-drug, non-surgical interventions to, aiming to reduce pain, improve function, quality of life, prevent or delay the need for arthroplasty. And we do a lot of randomised controlled trials. We also do a lot of research looking at translating evidence into practice and policy. So looking at what are the evidence practice gaps, trying to understand the barriers to care using behaviour change theory, improving access to care via telehealth and e-health, and also upskilling clinicians to deliver quality care as well. As I said, we've done numerous randomised controlled trials, and I've done 43 over my career, so a lot of clinical trials. And this is just some of the interventions that we've looked at. We've looked at testing footwear, weight loss programs, acupuncture, platelet-rich plasma injections, foot orthoses, physiotherapy, you can see there, walking sticks, video conferences, SMS, yoga, various exercise programs. So a real range of non-drug conservative interventions that we've focused on. And these have really provided evidence to help support the management of people with osteoarthritis. So I'm just going to give a little snapshot of a couple of projects and in our musculoskeletal area. And as I said, Adam will talk about the sports medicine area. One study we recently published, a randomised controlled trial, was the TARGET study. And we wanted to compare 2 types of exercise, neuromuscular exercise and quadriceps strengthening, in people with knee osteoarthritis who also have obesity. And what we found was that both of those two forms of exercise did improve pain and function, but there were no differences between the two exercise types. So meaning that, you know, either, whatever the preference would, either of those would be sort of equally effective in terms of pain and function. And that was just published this year. Another study that we've done was looking at text messages to see whether that would improve adherence to home exercise. And so in this clinical trial, again, which has just been published, we had two groups. One group did, or both groups did a home strengthening exercise program, and one group additionally got behaviour change text messages sent to them over 6 months. And what we found was that these did increase home exercise adherence over 6 months in people with knee osteoarthritis. We have Luke Davies, a PhD student who has started this year, and he's looking at developing a core capability framework for physiotherapists to deliver quality care via video conferencing, which is obviously even more important now that we've had COVID and a lot of physios have switched over to telehealth. So he's been working on that. We've got the Better Knee, Better Me study, a very large study that's almost finished with Medibank Private, where we're looking at Medibank members with knee osteoarthritis and who also have overweight and obesity, and looking at two different interventions, one that has physiotherapy consults via video conference for exercise and physical activity. The next one has both that plus a weight loss ketogenic diet with physios and dietitians, all delivered again remotely, and then a control group. And Medibank are going to roll out this program to their members next year. So that one, we've finished recruiting over 400 patients for that, and the study will be finishing in January. There's been a large body of work that Kim Allison has been leading, and Sarah Jones, one of our postdocs, has been doing a lot of work in as well, looking at whether physiotherapists can deliver weight loss interventions, because there's obviously a lot more physiotherapists than there are dietitians. And so we're looking at that question, and that involves some qualitative studies looking at what patients think about that, what physios think about that, but also now some clinical trials. We're going to look at the effectiveness of physios delivering that. So that's just a bit of a snapshot of some of the work we've got underway. And now I'm just going to really finish off with some of the translational research that we've been doing that's come from our research, because obviously we don't just want to publish it in journals and then that's the end of it. We want to make sure that it has an impact in terms of, you know, clinicians and for patients. And so following on from some of the work that we've done, we developed up and have released freely available Pain Trainer, which is an online pain coping skills training program that is an 8-module program, and you can access it there. So that is something that patients can do on their own, but obviously it's good that for clinicians to recommend it and then to sort of help patients through it with sort of helping with adherence. But that's a cognitive behavioural therapy program that we've made freely available. My exercise messages, and this is really work that's from Rachel Nelligan, a PhD student, and she developed up these behaviour change messages that I talked about that we looked at in a text program, but now we're converting it into an app. We're going to make that app freely available, and that app will help patients to adhere to their home exercise program. And so again, that's just currently being developed at the moment. Rana's going to talk about the PEAK program, so I won't really go into that, but just to say that that's free online training and resources for physios, so she'll talk about that. There's also been work led by Rana looking at a core capability framework for clinicians around how we should manage and what's the capabilities that clinicians need to have when they're managing patients with osteoarthritis. And that was a large international study, and it's now informing the development of osteoarthritis training modules via a MOOC that the Department of Health have given a large amount of funding for. We've also been doing a lot of advocacy or helping with advocacy for telehealth for physiotherapy care and working with the organisations like the Australian Physiotherapy Association. And we produced a rapid evidence summary back when the pandemic started. and they've used this evidence summary to help lobby, the APA have helped lobby for funding for telehealth over the pandemic, and that was really successful. And obviously physios have been delivering that care, but we want to be able to ensure that funding is maintained and continues once the pandemic is finished. So part of that as well is that we've been doing 3 different surveys of patients and clinicians, working with 3 different groups to look at the experiences of patients and clinicians with telehealth over the pandemic. And so we've been working with the APA, we've got another large survey with Allied Health Professions Australia, and we've also been working with the National Disability Insurance Scheme as well. And so all of this advocacy work really helping in terms of funding in the future. And then again, work from Rachel's PhD, great work that she did. She developed up a online website that is for patients with knee osteoarthritis, and it's a 6-month exercise, physical activity and education program that's fully self-directed by the patient with no clinician input. And we've now made that freely available, and Rachel tested that in a large randomised controlled trial as part of her PhD. So that's just a bit of a snapshot of some of our work, and we would encourage you to all join up our CHESM Knowledge Translation Network. That's where you can join up because this network, which we've already got over, I think, 3,000 or so clinicians from around 70 countries as part of that, and I think over 1,000 patients as well. And this network is where we can disseminate all of our products and resources and our research, as well as also invite people, clinicians and patients to take part in research as well. So it's a really good way to ensure that both patients and clinicians are integrally involved in the research. And I will leave it at that, but just to acknowledge and to thank the amazing CHESM team who have even been working hard, all working from home since March, but really productive and a lot of great research coming out. So thank you.
Thank you very much, Kim. So I'm sure, as everyone can see, there's a lot that's been happening in CHESM, especially over the COVID period. So I remind everyone, if you've got questions for Kim, please put them in the chat box, and we'll get to that shortly after Rana and Adam. So our next presenter is Professor Rana Hinman. She is the Deputy Director of CHESM and a physiotherapist who commenced an academic research career at the University of Melbourne in 2003. In 2013, Rana was awarded an Australian Research Council Future Fellowship, the only award in that year for clinical science, and she currently holds a National Health and Medical Research Council Senior Research Fellowship. Rana has received widespread recognition for her excellence in research, including a 2019 Faculty of Medicine, Dentistry and Health Sciences Industry Engaged Research, 2018 School of Health Sciences Award for Excellence in Research and Research Training, and along with Kim, won the 2018 Australian Council of Graduate Research Award for Excellence in Research Supervision. Rana is a world expert in the field of knee osteoarthritis and has made a number of significant contributions to the field, some of which we look forward to hearing more about now. Thanks, Rana.
Thanks, Tim. I hope everybody can see my slides. Can you see them, Tim? I can still see. Yes, great. Okay. Thanks, everybody, and welcome. I wanted to talk to you tonight about an ongoing research project that we've got going. But the reason I wanted to talk about it is because I know when I was a student, I never wanted to come back and be a researcher. And then 4 years later, I found myself doing a PhD, and then I never went back to clinical practice. One of the reasons I was never that keen on research was it seemed to take an enormously long time to achieve anything. So I wanted to present to you tonight a research project that we've got going on, but to also highlight how it's having impacts along the way. And so what Kim's already mentioned, what I'm going to talk about is the PEAK training program. Some of you may be familiar with this. So I won't talk too much about the main trial, but this paper is there, and I'll put up the slide at the end with a link to this publication. And this paper outlines the clinical trial, all of its protocol and methodology. But in a nutshell, as you can see here from the flow chart, it's a non-inferiority clinical trial where we're actually evaluating to see if telehealth by video consultations is similarly effective or non-inferior to face-to-face consultations. So you can see from the intervention here that the intervention ingredients that both groups get is the same, which is basically informed by evidence-based best practice osteoarthritis care. And what we're actually testing is the mode of delivery from those physio consultations. So we're comparing one-on-one video consultations via Zoom to one-on-one face-to-face consultations in the clinic, like you guys would be familiar with from your clinical placements. This trial is still ongoing. You can see we have a pretty big sample size to achieve, nearly 400 people, but we're well on the way with over 100 people recruited already. So we're not going to see outcomes from this trial for another couple of years, particularly given that you think we've got to recruit everybody. We have a 3-month primary time point for assessment with another 6-month follow-up assessment beyond that. So we're still quite away from seeing any outcomes from this trial. But what I want to talk to you tonight is about the training program that we developed. And the reason we had to develop that was because we've got 15 physios in private practice across Queensland and Victoria who are delivering our interventions in this trial. And when we recruit physios for a clinical trial such as this, we need to train them in the protocols that we want them to follow and the interventions that we want them to deliver. This isn't just going about usual practice, but it's following best practice care and also ensuring that they know how to deliver care via telehealth. This trial commenced last year, which was pre-COVID times. We didn't even know COVID was coming, and the vast majority of physios in Australia had never participated in telehealth, and most physios have never been trained in it. So in order to train up the physios for this trial, we developed a training program, and that's what I'm going to talk to you about tonight. As I've said to you, the ingredients of the intervention centre around patient education, provision of a strengthening exercise program, an individualised physical activity plan, discussion and education about OA that's centred around patient information booklets, and we actually provide a whole range of patient resources that can be downloaded, and also a website of exercise videos that are linked to the strengthening exercise program so that the physios can accurately prescribe exercises. But this website's particularly important for when patients are allocated to the Zoom video conferencing arm, because obviously in face-to-face care, physios will usually demonstrate an exercise, but a website and video library is really important for telehealth. This kind of gives you an outline of the key elements that we used for the trial. So we developed a range of e-learning online modules that have been delivered through the Uni Melbourne LMS. So the physios started with those e-learning modules. Then they went through a mock video consultation with one of our research staff to check their competency for delivering care over telehealth. After they passed through that gate, they then went through some mock or some practice consultations with some pilot patients to really put those skills into practice. And then after that, they were ready to start in the trial and receive their first patients randomised to them. So that really just gives you a little bit of a summary. Along the way, after we trained these physios, which training ended we had people training at different times, but that ended in January earlier this year, we did a qualitative study to evaluate what the physios thought of this training program. And we're just in the processes of finishing this manuscript, and we'll have that submitted soon. But you can see here from a number of quotes that a really strong theme that came out was how inexperienced and unconfident physios were with telehealth prior to doing the peak training. And in particular, also with online professional development, because most online professional development for qualified physios is typically face-to-face. And you can see that's nicely captured in that first quote on the screen there. And although physios were reasonably confident in their ability to use technology, they really didn't know how to deliver care via telehealth before this training. And a really strong theme that came out was how valuable training was once the COVID pandemic hit, in that although physios had trained in the peak training specifically for this clinical trial and specifically for knee osteoarthritis, they really were at the front of the game when it came to setting up and rapidly switching over to telehealth when restrictions and lockdown commenced and in-person visits had to stop. And on top of that, they were also training their colleagues. So that was really nice for us to see as physios and as researchers who developed that. This is just a little model that sort of brings together those themes from the qualitative study that we can see, where you can see the sample were really very inexperienced with telehealth, and they really felt that the whole package of training elements was really important for them to have the knowledge to help pass to bring that theory into practice and then consolidate what they knew, including their previous osteoarthritis knowledge, and ending with them being really confident in being able to implement telehealth. And so then the COVID pandemic hit, and we had at some point, probably at the end of the trial, intended to release this peak training after we had the results of the trial. But because certainly our trial physios and others out there in the community had heard about the training package we had, and physios were really clamouring for help and support in how to deliver telehealth, because most Australian physios, as we know, haven't had a lot of training in that. So we were encouraged to really quickly move to release this program online and free of charge. And we opened this up across the world. And some of you may have already may be familiar with the program, and if not, I'd encourage you to go in and have a look. You can certainly register as students. We've had a whole lot of students apply, and indeed lots of people other than physios as well. As I said, what we released is the online training modules. So we have 3 modules. The first one being focused on evidence-based osteoarthritis practice. The second being on sort of some general principles about telehealth. And then the third module, which is very specific to what the peak program involves. And it's very structured and takes learners through a series of 5 consultations, including what they should do, different elements of discussion, and as I said, includes a range of downloadable clinician and patient resources that physios can use. This is just some data since we released the program on April 1 this year, and this data is probably a month or so old now, but we've had over 6,000 user requests from over 97 countries. And this is just the pipeline of how people pass through the LMS program, with the blue box indicating the people engaging with the training program. We get our participants to complete a pre-training survey immediately before starting the modules, and again immediately afterwards. And we're now just in the process of implementing a survey 4 months after completing training, so that we can see if any of the learnings that people have gained, if they've actually implemented them into their clinical practice or their teaching. And I'll share some of those results. You can see that it's been very much a global uptake with 97 countries, and the top 5 countries are listed there. And really, it's been a really big snowball effect, with a lot of this spreading via word of mouth, by work colleagues, social media, and indeed a lot of the physiotherapy professional organisations around the world who've been really quick to try and help their members by disseminating any telehealth resources that may be available. You can see that of the participants that started our program, or that completed the pre-training program, the vast majority prior to training had never offered video conferencing to their knee OA patients. You could also, this data also shows how confident they were with using video conferencing prior to training. And what you can see is that if we look at that sort of higher end, only 22% scored 8 or above. Pleasingly, after training, we can see quite a shift in the scores around confidence, with 73% scoring 8 or above after training. In terms of how useful was the peak training program, we can again see that 80% of learners scored 8 or above with how useful they found the program. Now, I'm just going to touch briefly on the 4-month implementation survey, which is to see to what extent did the professional development here change or inform clinical practice or educational practice, because we had quite a few educators complete the program as well. And you can see that over half have stated that it's really influenced them to a moderate extent, which is great for us to see. And this slide really shows the really wide variety and the different ways that people use information that they gain from professional education. You can see that the information booklets were really, really highly valued by users, with almost 20% using those information booklets in their practice. But also the structure, the very structured nature of the consultations and the content was also used to inform not just the telehealth, but also their face-to-face consults. So you can see a whole range, with only a very small number saying that they hadn't implemented anything from the peak training program. And with a lot of those users, it was really, the reasons for that was because they were focused on the telehealth, and in some countries around the world, telehealth is not funded nor supported by their health organisation. Finally, what's been really nice for us to see is that the uptake and the advertising, where we're now seeing private practitioners spruiking the fact that they offer the peak program and using it for marketing. We've now got translations underway in a whole range of languages that are happening as we speak. And we've certainly seen it creep into university curricula as well, including at the University of Melbourne DPT. Finally, just to finish up, I'd really like to acknowledge the large amount of work that's been done by both Alex Kemp and Penny Campbell, who are part of the research team here at CHESM and have really been spearheading a lot of the work of the trial and the implementation of the peak program, and our funders. And if you want any further information, you can email me or check out our peak protocol, or, as I said, log in to register for the training program. Thanks very much.
Thank you very much, Rana. I'm sure many of the DPT students will become familiar with this as they move through their career. Our next speaker is Associate Professor Adam Bryant, who is a biomechanist and head of CHESM's sports medicine stream. Adam's research is focused on the neurobiomechanics of the musculoskeletal system, with an emphasis on the role that muscles play in the mechanical loading of healthy and injured joints and the subsequent adaptive and maladaptive responses. A major area of his research is the knee joint and the anterior cruciate ligament injury, where he has investigated the dynamic restraint mechanisms contributing to knee stability and the function following ACL injury and reconstruction. He has published almost 120 peer-reviewed papers and has received over $4.5 million in grant funding. Adam is a previous recipient of the NHMRC Career Development Fellowship and has a current ARC and NHMRC project funding. He has extensive links with industry and has won numerous awards, including the Sports Medicine Australia Best Investigator on 2 separate occasions. Until recently, Adam was also the Director of Research for the School of Health Sciences. Thank you, Adam.
Thanks, Tim. Do I have share screen function?
Michelle might need to, or Belinda, give you the rights. That might be why. I'm not sure if they could do that.
Sorry, everyone. Yes, I do.
There you go.
Okay, so thanks Tim for the introduction, and thanks to the organising committee for the opportunity to speak with you tonight. As Kim said, I'm looking after the sports medicine research program, and tonight I'm going to talk just a little bit about past, present and future directions. I hope I haven't made this too sort of overly technical and whatnot, but I hope it makes sense. There's a fair bit to get through, and let me start by saying that this is just a snapshot. It doesn't encapsulate all of the research that's been done in the sports medicine stream. For example, Cade and Pat Rowe and myself have a new project on ankle instability. Steph Filbray has recently joined our team, and I'm not going to talk about her research, but I'm sure you'll have an opportunity to hear from her in terms of her sports medicine related work. So this is, as I said, it's just a snapshot, and hopefully you can get a bit of an idea of the directions that we've taken over the last few years. Unlike Kim and Rana, I'm not a clinician. I did an applied science degree and I received honours, and then went on to do a PhD in biomechanics from the University of Wollongong. It's not a particularly prominent university, but I attended there because I had relevant supervisor experience. I worked in smaller unis in New South Wales and Queensland before my University of Melbourne appointment in 2005, which was almost 16 years ago. My goodness, time flies. I am an associate professor and head of the CHESM sports medicine stream, and I've mostly had a combined teaching and research appointment, apart from 4 years, as Tim said, where I had an NHMRC CDF fellowship. I've had various administrative and leadership roles, including the Director of Research from 2016 to 2019 in the School of Health Sciences, and I'm an MDHS representative in the Melbourne School of Engineering Medical Research Working Group. So unlike Kim and Rana's work, our work is really focused on younger cohorts, particularly adolescents, young adults and middle-aged individuals. And we've really focused on understanding the roles that muscles play in the mechanical loading of healthy and injured joints and the subsequent adaptive and maladaptive responses, both in respect to function and structure. So when I spoke to Michelle about tonight's presentation, I got to think, after I spoke to Michelle, I should say, I got to thinking about people who'd sort of made an influence on me and sort of directed my research. And really, for me, it came back to, I guess, a couple of people early on, and it was really Peter McNair's work from the 1990s, his PhD work and beyond. And he used really creative, albeit somewhat sophisticated, novel biomechanical approaches to look at copers in the ACL deficient population. And that creative sort of out-of-the-box type of thinking really set the scene for my research career. In particular, and as an example of that, he was really the first to look at things like the viscoelastic properties of muscles and how they relate to joint stability. Peter's now a professor at Auckland University of Technology, and we remain friends to this day. So I've picked 4 areas that I'll talk about just very briefly tonight, just as I said before, just to give you a taste of the work that we've done. So the first area is neuromuscular and biomechanical adaptations associated with ACL injury and reconstruction. So as I'm sure you're all aware, the ACL is kind of the rock star of the sports medicine area. It has lots of roles. It provides stability, anterior stability and rotational stability, and it also provides the central nervous system with the neurosensory information. So it's quite critical. So when the ACL is injured, there's a rather complex and often serious consequences as a function of that. Now, there are 2 main options for ACL injuries. The first is surgical, as I'm sure you're all aware, and the second is conservative, which is, unfortunately, it's not overly popular in Australia. But importantly, in our research, we've looked at both surgically and conservatively managed ACL patients. So I'll just take you back to the joint stabilisation system, and with respect to this, we've really looked at the interplay between each of these 3 subcomponents and how they relate to function following ACL injury and reconstruction. And We've had a long series of papers actually completed by some great postgraduate and PhD students over the years. So for example, we've had Luke Perrotton's work. Luke is now a lecturer at Monash University in the Department of Physiotherapy. This paper was actually led by Michelle Hall, who's obviously a critical member of our team. Sarah Ward has done some great TMS work in that space. And Ross Clark and I have worked together for many years before he subsequently left and went to the Australian Catholic University. So there's been a rather substantial contribution by lots of people in this space. So the second area that I'd like to talk about, and this really follows on from the first, is knee structure and associations with knee biomechanics following ACLR. So again, I'm not going to go into too much detail, but both ACL deficient and ACL reconstructed patients have high rates of OA in the first 10 to 15 years. There's no indication that the rates are decreasing, and in some reports it says that OA is actually increasing. So there's a lack of evidence showing a long-term protection of the knee joint after ACL injury and reconstruction. So that really led to our NHMRC project grant, which was called Young People with Old Knees, Knee Ligament Reconstruction and Early Joint Changes. So I led this particular study, but it was certainly Kim that mentored me through this process, and Flavia and David and Tim also made some substantial contributions to the success of this project. We had 2 sites in Melbourne and the Gold Coast. We had a very large ACLR cohort of 120 patients and 60 controls. Our primary outcome was the change in knee joint structure, and we looked at defects, volume and BMLs. And importantly, we looked at the factors that actually contributed to changes in joint structure from 2 years to 4 years post-surgery. Again, just briefly, in terms of some of the structural changes, we looked at annual cartilage volume, and this was one of our PhD students, Yang, and he's actually enrolled to do physiotherapy at Swinburne University next year. He started out as a medical doctor, went into an orthopaedic training program, and has decided to actually come back and do physiotherapy. So he looked at the annual cartilage change over the course of the study, and as you can see there, we had hypertrophic changes in the medial tibia, the lateral tibia and the patella. And obviously, for those of you who aren't aware, that's an adaptation. It's not necessarily a positive adaptation, but it's indicative of disruption of the cartilage, of the collagen within the cartilage, draws water in to act as a protective mechanism, so we think. The second part of Yang's study actually looked at compositional changes in cartilage. So we used T2 relaxation and we looked at the different layers. So we looked at the full thickness, we looked at the superficial layers, and we looked at the deep layers in the tibia, the femur, the trochlea and the patella. So in this particular type of analysis, T2 values are representative of cartilage degeneration. We did find an increase in T2 values in some of the compartments and some of the layers, but strangely enough, or interestingly enough, I should say, we actually found a reduction in other layers, suggesting that the changes in cartilage structure are definitely fluid in this particular cohort and not always deleterious. So the second part of this particular study was really looking at quantifying lower limb biomechanics in a very sophisticated way, and we used musculoskeletal models to actually calculate contact forces. So we used information from our gait experiments, from the Vicon, EMG, and we collected kinematic and kinetic data. We put this data into musculoskeletal models, which were developed by David Saxby, who was another PhD student who was working on this project with David Lloyd. And then from that, we were able to calculate the muscle forces and the joint contact forces over a series of different tasks of increasing intensity. So this was the excellent work that Dave Saxby did in a paper called Tibiofemoral Contact Forces in the ACLR knee. 104 of the participants that I mentioned previously were, we got good data for. We also had data for 60 controls. We looked at walking, running and sidestepping, and we used an EMG-driven musculoskeletal model to calculate those muscle and joint contact forces. As a credit to the Griffith University team, we had some really nice adaptations to a generic EMG-driven model where we accounted for the donor muscle impairment. So what did we actually find? And this is probably one of the more exciting research findings that I've been involved with. So it's a little bit hard to see, but what we found was that for walking, running and sidestepping, the ACLR patients actually had lower joint contact forces compared to the control participants. So unlike some of the hypotheses that have been put forward around this cohort in the past, they weren't actually overloading, they were actually underloading. This remains one of the largest MSK modelling studies to date. As I said before, it shows that the TFJ is underloaded in a variety of tasks, but the question remains, do these knee contact forces relate to MRI-based structural measures? And the final part of this particular study, and there were numerous other papers that came out of it, was to really look at the relationship between structure and loading. And what we found was that increased medial contact force, so those individuals, those ACLR individuals that had higher levels of medial contact force actually had reduced odds of medial cartilage articular defects and also reduced odds of large PMLs. So in conclusion around this, increased knee loading actually contributes to better joint health post-ACLR. And this clearly has important implications for rehab post-surgery. We're still working out ways to actually do that. Another area which, strangely enough, Tim, this is really a focus of his work that he did as part of his PhD, and was the effects of female pubertal development and athletic footwear on lower limb biomechanics. And somewhat concerningly, ACL injury is actually, or ACL reconstructive surgery is actually increasing, and by association we think that ACL injury is also increasing. There's no ACL registry at this moment, so we're based on these surgical numbers. So as you can see, it's gradually climbing, and alarmingly what we're finding is that the incidence of primary ACLR is increasing in females, particularly in this young category, these teenagers and these young adults. So we endeavoured to look at the effects of athletic footwear and lower limb biomechanics of girls during pubertal development. And this was really a team effort. So it included Kim and Rana, who were obviously invaluable. Cade, who also, his knowledge of foot biomechanics was fantastic. And as I said before, Tim Sayer used data from this particular study for his PhD. We had ASICS Oceania as our industry partner, and they've been very, very generous to us over the years. We looked at 3 stages of female pubertal development. We looked at pre, early, mid and late post, and Tim, I've borrowed your diagrams there to indicate the 3 development stages, and we looked at high and low support ASICS netball shoes. And then we looked at knee and lower limb biomechanics during running and single limb drop lateral landings. So as I said, Tim used data from this particular study for his PhD, which he submitted, which was actually awarded in 2018. The main task that we looked at was this one here. We did a single limb landing task where participants dropped off a box and then hopped laterally and landed on their contralateral limb. So we tried to use a fairly controlled task to look at the effects of puberty in footwear. So Tim obviously has been very productive. We published a whole host of papers, or a host of papers from this particular study, looking first of all at puberty and footwear and the combined effects as well. Again, one of the more interesting findings of my research career. So this was the knee joint moments, the abduction moment, the flexion moments, and the internal rotation moments across the 3 stages of pubertal development. And as you can see, they increase across those 3 stages. And they do provide some indication as to why these girls in late post-puberty have an increased risk of ACL injury. Now, when we looked at the effects of footwear, we found that the shoes didn't do a whole lot in that frontal plane, which is probably a good thing, but unfortunately they elevated the sagittal plane and transverse plane moments. So really, that has led to subsequent studies. So female pubertal development contributes to an increase in these moments, and commercially available athletic footwear increases in the knee flexion moments, and we really do need better designs. We've also used this particular data set that Tim collected in collaboration with Karen, who was a research assistant with us. And we've used that data to actually look at in vivo ACL loads. And this is another really exciting area. So working with Dave Saxby and David Lloyd at Griffith University, we've actually been able to model the ACL and calculate the ACL forces as you can see here, as a function of this particular task. And we've looked at the contribution to ACL loads in the sagittal, frontal and transverse planes. And excitingly, we're going to use this particular model in subsequent studies. So we're really excited because this is the first validated model that can provide an accessible tool to develop and test knee ACL injury prevention programs for people with normal ACLs. And we're looking also at adapting that for the ACLR population, given that they don't have a normal ACL, so to speak. We've just submitted a paper, again, using this data, and we've compared the pre-puberty versus the early and late puberty cohorts. And as you can see from this blue line here, the late post-pubertal group has dramatically higher ACL forces compared to the other 2 groups, which really does, again, feed into that mechanistic explanation of why they're predisposed to these types of injuries. Just quickly, athletic footwear for reducing knee loads in girls and women. This is a follow-on study from the aforementioned or the previous linkage grant. Again, includes Kim and Rana, Cade, and biostatistician Jessica Kaza. ASICS, again, is the industry partner. We're looking only at the late post-pubertal females because of their aberrant knee biomechanics. And what we're doing is using multiple netball shoe variants, as you can see indicated down on the bottom right, to see which is most effective in lowering those knee and lower limb loads during single limb drop lateral landing. And importantly, William, who is one of our new PhD students, or he's not that new anymore. Pee-wee Chi is his full name. He's from Taiwan, but we affectionately know him as William. He's working on this particular project, which has been on hiatus since the COVID-19 restrictions. William's been doing some great work in that modelling space, as you can see depicted here, and we're definitely finding some interesting differences in anterior shear forces between the footwear conditions. Look, I think I've run out of time, and I don't want to hold people up too much, but just briefly, we're looking at exercise-related RCT for chronic low back pain. We've done a number of studies in this particular space. We looked at normal strengthening combined with neuromuscular retraining over a 12-week period, and we actually found no differences between the 2 groups. But what we did find was that they improved dramatically in their disability, and also their pain intensity decreased. We're also using some computational models to look at joint contact forces, muscle and joint contact forces in the lumbar spine from this particular study. Tim, have I got 30 seconds more?
Yeah, take 30 seconds more. Sure.
Yep. So future studies, for anyone who's interested, we really want to look at the effects of modified footwear features on ACLOs in patients having undergone knee surgery. So we'll be seeking funding for this particular study. And another study, again, looking at the effects of footwear on ACL forces, where we're aiming to develop a novel instrumented women's smart Australian rules football boot that can actually enhance athletic performance and minimise ACL loads. But what we're endeavouring to do is integrate these smart wearable technologies in the form of these insoles so that we can provide participants with ground reaction force data and also spatiotemporal data. Okay, and I might leave it there. Thanks, Tim. I'm sorry if I went a minute or so over.
No, thanks very much, Adam. And thank you to Kim and Rana. I haven't received any questions in the chat box function yet, but I open the floor to anyone who wishes to ask a question to either Kim, Rana or Adam now, and feel free to take your microphone off mute if you want to ask them a question. Not sure if we're going to have any takers. Nobody? Okay, well, if there's no questions, given the time, we might move on. If I just double check with Michelle and Belinda, do you want to have a 5-minute break or do we want to keep going? You're okay if we keep going, Michelle?
Yeah, no, I don't mind. I don't mind. Whatever people
else
feel.
is okay, and I guess, Tor, are you okay to start again now?
Yes, I'm good to go.
Okay, perfect. So I'll hand over to Tor now, who will take you through some DPT research experiences and our postdoctoral fellows. Thank you.
Thank you very much, Tim, and all of the previous speakers. So I'd like to welcome everybody to our rapid fire panel session. So we've got 2 panels with 15 minutes each, so I won't delay in getting stuck in. So I'll ask our first panel members to unmute and turn their video cameras on. So our first panel is some DPT students who have recently completed a placement with CHESM, and I'll just ask them to just briefly just explain some of the experiences that they had during their research selective with CHESM, but making sure that they don't take up too much time so that there is an opportunity for some Q&A afterwards. So we'll start off with Adam.
Yeah, sure. So I'll just quickly explain what we did. So I was with Ksenia and 6 other students working with some of the staff at CHESM, and this was part of our selective placement. So if we were interested in teaching or research in the future, we were allowed to take on this placement as just to get a feel of what it's like to be in teaching or research in the future. And our project was kind of in line with Professor Rana Hinman's PEAK module, but instead of knee OA, we looked at hip OA, delivering hip OA physiotherapy on telehealth, and we're still at the developmental stage of formulating the E module, so we were lucky enough to help out a little bit in that field.
Great, thanks very much, Adam. Ksenia, are you okay to give a brief summary of the experiences you had during your selective with CHESM?
Sure, it's exactly the same as Adam's. We worked together with some of the students in our cohort, and we helped develop resources for this hip OA program. We did some videos to include in the hip OA program. We made some infographics, things like that, just to bring it all together and be able to display it when the final product comes together.
That's great. Thanks, Ksenia. Catherine, are you good to go?
Yep, I worked with Dr. Belinda Lawford on the NDIS survey that was mentioned earlier, and we looked at the participants' experiences with telehealth, which was very current and very relevant, which was interesting. And it was a large survey, so there was lots and lots of data, and I got to help do a literature review, write up the methods, the results, and interpret the results as well. So it was very real.
Great, thanks, Catherine. And finally, Ryan.
Yep. So mine was similar to Kate's. I was with Belinda and Steph as well, and mine was to do with the telehealth approach as well, with amongst like a broad range of allied health professions. So occupational therapy, speech pathology, diabetes education, and podiatry. Just looking into the perceptions and safety and effectiveness of telehealth, especially during COVID. And that was quite a large survey for both clinicians and clients. So understanding both sides of the field there. So quite a large lot of data, but very interesting and insightful.
That's great. So there seems to have been quite a range of different experiences across you all. So I'm just wondering if there are any questions first up. Otherwise, I'll jump in with my questions.
I have a question, if that's all right.
Thanks, Jacob. Yeah, go ahead.
So I was just wondering, having just recently moved from studying in the DPT course to working in research, was there anything that you found surprising or different working with researchers than you were expecting before going in?
I'm happy to start us off with that one. I was quite surprised at the responsibility that I was given and the confidence that the researchers had in me. So in terms of the writing up the methods and results and literature review, I was working more in collaboration, and I was able to have a lot of independence, and my ideas were really respected. So I was quite surprised. I mean, I really enjoyed Research and Evidence 1, 2 and 3, but I thought that maybe I would need some sort of special skills or something like that. I had barely used Excel, barely used SPSS. But no, the R&E subjects really set you up well. So it's easy to transition to, and I was quite surprised by that.
That's great. Looks like Adam's got an answer to that one as well. Thanks, Adam.
Yeah, sure. So I think not so much surprised, but what really I really enjoyed about my placement was how translational that research was. So I think Professor Kim Bennell touched on, doing the research and then actually translating into something practical. Ksenia and I were part of that kind of translation of knowledge into a practical e-module training program. And I think that was quite fulfilling for me. And yeah, so I really enjoyed that. Anything to add, Ksenia?
I definitely enjoyed collaborating with the researchers on more of an interprofessional level. So they really treat you like they're your colleagues, and I found that not necessarily surprising, but I really enjoyed that aspect of it, because it's a different dynamic than sitting in a lecture theatre. You're collaborating, your input is really valued, and it's actually an amazing work environment to participate in.
Ryan, do you have anything else to add in terms of what surprised you about the experience that you had with CHESM?
I think everyone's pretty much said it all, to be honest. Yeah, I was quite surprised how well prepared I actually was in the end through, the R&E subjects, and that despite not really feeling like it initially. I thought I had no idea what I was going to be doing, the research side of things, but yeah, was actually quite prepared in the end and seemed relatively successful. So yeah.
Hey Ryan, I'm going to follow that one up with another question straight to you from me. And I was just wondering, in what ways do you think that your experience during the selective with CHESM has helped you in your practice as a physiotherapist after qualification?
Oh, I think, good question. I suppose it's kind of highlighted a bit more for me, like the telehealth side of things, how effective it can be, has kind of given me a bit more of an insight into, the perceptions that both the clients and the clinicians get. So we'll be able to help to adapt practice in the future when that becomes, necessary.
Thanks. Have Adam or Catherine or Ksenia, have you got anything to add in terms of how you think that the selective has set you up for a future career, either as clinical or something else?
Yeah, I guess specifically speaking about telehealth, I think I echo Ryan's thought. Funnily enough, my placement straight after my research and teaching placement was in telehealth, so it was kind of nice to see that translation of what we've been doing on the research side and developmental side in practice. It wasn't specifically for HIP OA, but it was nice to see that translation. But I think more broadly speaking, this placement has kind of given me a lot more insight into what it's like to be in that kind of academic field. And I understand lots of people combine clinical work with academia, but it was a really nice way to kind of get a taster of what that's like. So if any of the DPT 1 or 2 students are interested in research or teaching further down the track, I highly recommend this placement.
I think just to add to that, it's given me personally a lot more confidence to approach researchers or individuals involved in research in the future, because I guess I just didn't know how to do it, how well it would be received, and it's given me a lot of confidence to say no. A lot of researchers who are working on their projects are very enthusiastic to have students approach them and engage with them about their research, and it's quite easy to do, and you've got a lot of really accessible, highly intelligent professionals at your disposal, and I definitely recommend to use that network.
Thanks very much. I was going to comment on some of the themes that have come up in what you've said so far. Would be several of you have used words like confidence and also being prepared. So I wonder that the feeling that you had of being prepared through your research and evidence and practice subjects, and the confidence that gave you, is also something that you might sort of like feel like might happen when you go out into the real world of clinical practice now, that you maybe feel that you are actually really well prepared and you do have some confidence to go forward. Any other comments? And any other questions from anybody else before I take over again? Okay, I'll come up with another question. So can you think of a specific task that you did that you found most enjoyable during the experience?
Well, I think Adam and I are going to, oh, sorry. Go ahead.
I'll go quickly. This is quite interesting. I know that in DPT1, we were asked to download EndNote and use it. And I tried to, but I just, for some reason, couldn't manage it. Anyway, I really enjoyed using EndNote for the first time in this placement, and it's definitely worth using if you can. So I really enjoyed my literature review because EndNote simplified it, and it felt good to use all the skills that we'd learned in R&E to look up the relevant literature and pull it all together. I just felt quite proud that it was sort of this final product literature review all done at once with the help of EndNote.
That's great. I love to hear a fan of EndNote. Anybody else?
I don't know if Adam is going to echo my enthusiasm on this, but I think our group did a fantastic little educational cartoon video on HIP OA. And I think I'll throw out a little shout out to Jacob for narrating it with his very smooth and sophisticated narrative voice. And it was really, really great to put together this video, giving a bit of patient education and creating some clinical scenarios for how you would educate your patient and what kind of language you'd use. I think we really smashed that one, and I think the final product we were really proud of it.
Yeah, absolutely. I think the process of developing it as well was a real team effort.
Mm-hmm.
with coronavirus, obviously we don't have face-to-face contact, but the CHESM staff, namely Fiona, Gabby, and Michelle, they made time for us to meet every week, and they gave us some really good feedback as well. And it was a nice kind of team effort working towards one thing. So yeah, it was nice. I really enjoyed that placement.
That's really good. We do have one question that's been posted in the chat now, so I'll just read it out and let anybody answer that. So the question is, how did you all come to do your selective with CHESM in terms of who did you contact to get this organised, and how were the projects organised or chosen for you to get involved in?
Okay. With that, we contacted, I'm not sure if this is for everyone, but I contacted Deb in organising. So we've got 2 placement blocks for second semester, third year, and one's work transition and the other one's professional selective. And the professional selective placements are dedicated to an area that you are interested in working in the future. So whether that's private practice or a stream in hospital, and for us it was the teaching and learning placement. And I contacted Deb telling her that I was interested in possibly teaching in the future, so I wanted this placement. And in terms of selection of the research project, we didn't have much say in it, we were just assigned it, but yeah, it was that's how it was organized for me, at least.
For me, it just kind of fell into my lap because my private practice placement got cancelled due to COVID. But it was a great alternative, and I chose it out of sort of the remaining options, and let Deb know my preference. And she was really happy to promote it and make it really readily available for us as students.
That's good. We do have one last question, which I think I'll just get a very quick answer from everybody too. It's come from the floor, and it says, would you now consider a career, either full-time or part-time, in research, having survived your selective with CHESM?
Yeah, I was always considering it, and it was good to know what it was like in real life. I'm considering clinic first. I'd like to do my clinical skills while I've got them. And then, yeah, definitely a bit of research as well.
Yep, same as well. I think getting a bit of clinical experience first and then see where that takes me, but I'm definitely interested.
Ryan?
Yeah, so similar for me, like research is always kind of the thing that's something I might, look into in the future. So to get this placement and to get a little bit of exposure and experience, been great for the confidence to know that if I do want to entertain that option, like I can do that in the future. Yeah.
And Ksenia?
I never considered research as an option, to be honest. I was hopeless at RNE 1 and 2, and it did change my mind, and I did really see the value in it, and I can see myself doing research in the future like the others after a bit of clinical practice, and I would be really happy to collaborate and work with these people on projects in the future.
That's great. Thank you so much, panelists. It's been really nice, and sorry it's been a rapid fire panel session, but I'm going to swap over to our second panel now. So this next panel is a panel of postdoctoral researchers with CHESM. So postdoctoral means that all the panel members have completed a PhD and they're now working either part or full-time in a research role. So I'd like to introduce Dr. Stephanie Philbay, Dr. Kate Patterson, Dr. Belinda Lawford, I'm thinking Belinda is here somewhere, Dr. Michelle Hall, and myself is Dr. Tauline Edgerton. So yes, as I said, we're all working in research roles, either full or part-time. I was also going to mention that we're actually fewer than half of us are physiotherapists, and I wonder if anybody out there has got any questions for our postdoctoral panel. And apologies if my video keeps freezing, because at the moment I can't see anybody at all. So I'm flying blind here. And I've got a question. So, and I can't even see who's live and who's not. So I'll randomly pick on people and hope that they're there. But the question is, what made you decide to do a PhD in the first place? So Kate, would you be able to answer that question first?
You'd pick me, Tor. Yeah, look, I had started in biomechanics. I'd done sort of an honours year in biomechanics, and then and it was in sort of foot mechanics. So then went and did podiatry, and then started practicing as a podiatrist. And I had the research bug from the start. So my honours year, I just absolutely loved it. And so I sort of kept in contact with my honours supervisor. Along the way, during my clinical work, I kind of picked up a little bit of work in the lab, and it just fed from there. And eventually it turned into a full-blown PhD. So I ended up doing that part-time whilst teaching part-time and working clinically part-time.
That's great. That's a great answer. Thanks, Kate. Steph, are you there?
Yeah, I am. Yeah, my pathway was almost by chance, I suppose. So I'm a physio, and during my last year of my physio course, we had an honours by research year. So on top of all your other subjects, you could do a systematic review and a study throughout your last year. So I did that, and that was in cardiac research, because you didn't get to choose your project. And I'm just saying that because I'm naturally interested in sports and musculoskeletal research, but I did it in cardiac research. And I was up presenting my results at the APA conference up in Brisbane. And from that conference, there was sports physio drinks one night. And I thought, oh, should I go? I don't know anyone. No, I won't go. You know, it's not for me. And then I did decide to go, and I didn't know anyone. And from that one event, or networking, I suppose, I met some really great people and had some discussions, and got offered to do my PhD that evening in ACLs, which is, you know, I'd already had an ACL reconstruction, and I'm really passionate about ACLs. And I was also offered a really good sports physio clinical job that evening as well. So I had a really big life decision to make. Do I go clinical, or do I do a PhD? And it was a really tough decision, actually. It wasn't easy. But I decided to do a PhD, and I think that definitely was the right decision. So.
Yes, I would agree. It does seem to be a very good decision, Steph, because the research that you've achieved and looks like you will continue to output in the future is amazing. Oh, Michelle, have we got you there?
Yes, so hi.
I can't see anything. So why did you decide to do a PhD, Michelle?
Yes, well, it's a bit like what the guys have mentioned. You sort of get the research bug, and it's sort of a natural progression after your honours. And after I finished my honours in Dublin, back home in Ireland, I really wasn't sure I'd be fit to do a PhD. It seemed like something that would take a very long time, and the people around me weren't so sure about PhDs. They were sort of in the latter stages of them, and maybe not quite as excited as when you start. So I decided that a master's might be the next step, and I'd sort of use it to travel a little bit. So I went to America and did a master's. But once I finished the master's, I was dead sure, yeah, no, that this research is for me. And so I embarked on the PhD and came to Australia.
Thanks, Michelle. And Belinda, are you there? Yeah, I think she's not there, not available, and that's fine. So my next question was kind of sort of directed to those of us that are doing a bit of a mixture of research and other things. So, so just from my perspective, I'm a teaching and research position now, so I'm half teaching and half research. And that's a really interesting balance. The best thing about that situation, I think, is that I've got immediate ability to translate research straight into practice via educating the students, both you know, pre-qualification or pre-entry to practice, and also postgraduate. So that's a really big plus for my situation, I think. But I'd like to throw that one back to Cade, because Cade's doing both clinical work, a little bit of teaching work, and a lot of research work. So how do you juggle all of that, Cade?
Surprisingly, I won't say easily, but I have to compartmentalize. So I have my clinic time, which obviously is sanctioned time. For me, it's a Wednesday and then every second Saturday. So research doesn't really bleed into that at all. I think something that will probably come up a little bit, I think has already been mentioned, is that the research career is also quite flexible. I know Kim mentioned it before. We are able to work to a certain extent, you know, out of hours when we need to, and we can have gaps where we need to. So I've found the juggle just really natural for me. It works quite well for my lifestyle, and I've never really had a problem combining the two. One thing that has happened for me sort of over the last 10 years is that I've gradually reduced my clinical time and increased my research time. But that's been a deliberate choice, and I've certainly benefited from that, and I'm quite happy with that choice.
Yeah, I'm not sure if Steph or Michelle have got anything to add to the work-life balance question.
Yeah, I mean, I could add in terms of, so during my PhD, I worked in private practice 3 evenings a week, and for sports teams of a Saturday as a physio. And I also was a lecturer in the physio course while doing my PhD. So it seems like a lot and a lot of work, but I actually really enjoyed it. And I really enjoyed the flexibility of doing different things and not having a monotonous 9 to 5, you know, job where you're doing something repetitively. And it really breaks up the day and it keeps things interesting. I don't know, for me, it kind of never felt like work. It was going somewhere else and doing other things that I enjoy. So I think there can definitely be benefits in the flexibility, like Cade said, but also the ability to mix up your day and do different things, both clinically and in research.
I think Steph touches on a really good point there with the clinical work as well, as that often that is an evening or a, you know, half a day on the weekend or something like that. So they can blend together quite well.
I think I sort of touched on sort of the next topic. So we were talking about balancing different roles within our jobs, so research, education, clinical practice, and so on. But what about work-life balance? How does everybody manage that? How do you manage to keep your life going when you've got this sometimes overwhelming amount of work that comes with research?
Yeah, well, I think it's like most things, there's always something to do. You know, you're never quite finished. There's always that next thing that you know, you've kind of want to go. But I think it's about being disciplined with yourself and what you do, priorities that you want to set for yourself and what in your life at that time. But of course, they bleed into each other. But the flexibility that you have with the job allows it to do that.
Kay, do you have a life?
Sometimes. I'd just echo what Michelle said. You really need to be organised and disciplined. So occasionally that's going to, at certain times of year, it's going to spill over. For anyone that knows the research world, grant time is notorious. And you know, you put a lot of things on hold for those things, but you also have other deadlines. But look, the flip of that is that you then can have downtime when you need it. So you certainly do have busy times and that can eat into personal life. But as I said, the flip of that is that you then often can have personal life eating into work time. So for me, for example, you know, I have kids, and taking the kids to school and picking them up is not a problem. And I couldn't do that if I was in the clinic full time.
Oh, it's just, yeah, okay. So I think we've got time for one more question, and one has just come in. So the question is, how much time and effort do you spend writing / securing grants? And is this a constant source of stress as a researcher? I think that's an excellent question, and we'll see what our panelists have to say on that.
Okay, sure, I'll go first. For the writing, I would say writing is a really big part of research. You do become an author. An author involves writing. So I think you know, if you enjoyed English in school, or if you do actually enjoy to express yourself through writing, you might actually really enjoy research. You can't get away from writing altogether. For me, I really like writing, so that helps. But in saying that, it's a career in research, there's lots of different things that you do, and you're never just doing the same thing. So you're analysing data, then you're writing, you're doing a presentation, you're mentoring a student. That's a really varied sort of lifestyle, which I really enjoy. And in terms of grants, yeah, I mean, that for me would be the main negative of a career in research, is the having to kind of compete for your own salary and your own funding, if you will. It's not constant, you know, it's a few really productive weeks where you have to sit down and dedicate the time to writing the grant, but it isn't constant. And then if you get one, you have a bit of a break before you need to apply for the next one. It's not the end of the world, I don't think.
Michelle, would you like to add anything there?
Yeah, I was funny, Steph, when you were saying about the English, because English was my worst subject at school. It was horrendous. So, you know, about the writing, because English was also, you had to think about these poems and what is Shakespeare trying to say to me? I don't know, but you don't actually have to go down that pathway when you write scientific papers. So if you didn't fancy English in your, it's okay as well. Yeah, I suppose just in terms of grants, is it stressful? Yes, they are stressful, because sometimes your salaries do depend on that. Sort of depends on the structure of your position. But, you know, if you are working as a clinician, as a researcher, you know, you're not all in and dependent on research funding. So you certainly have a clinical aspect to your career.
Michelle, I'm totally with you in the English thing. I was terrible at it at school, and yet it's now one of my favourite parts of a research job. It's interesting, right?
Yeah.
I am going to, time's up, I'm afraid. So we do have one other question, and it was just about wanting to know how we got into our research, and how people can get into research from a DPT. And there's a lot of different pathways into research, and I think that's something that we'll be discussing, and that'll kind of be the topic of the next meetup that we're planning on having in the early part of next year, hopefully. So hopefully we'll get to that question soon, and hopefully there's a lot of you out there that are interested in keeping going with this seminar series, and are interested in finding out a bit more about a research career, or a bit more about musculoskeletal research in general. So I'd just like to quickly thank both of our session panelists, and I'll conclude the evening by thanking everybody for their attendance and your interest in musculoskeletal research, and in CHESM in particular. So on behalf of CHESM, I hope you've enjoyed the evening. We very much look forward to meeting you all again soon. But for now, goodbye and good luck with your future studies and future careers for those of you who are nearly finished. And with that, I'll draw it to a close.
Thanks. Bye-bye.
Bye.